Hi, this is Dr. Greg Coppola explaining to you a little more about regenerative medicine. So on the model here, we talk about the struts, the rotors, and the brakes of a car and how they get worn by the use of the vehicle. Well, similarly, our connective tissue, which is made up of ligaments, tendons, cartilage, and the joints, begin to wear as we become middle-aged. And so this structure right here is called the medial collateral ligament. It connects the femur to the tibia. It is a major stabilizer for the inside part of the knee, and it actually connects to the medial cartilage on the inside of the knee. We know through many studies that the most common area to degenerate and tear inside the knee is the posterior part, the back part of the meniscus or the cartilage. So this whole structure tends to get worn with the wear and tear of daily life, and then layering on some athletic activity for some of our patients. When this strut gets worn, the knee becomes unstable and the body starts to lay down extra bone growth, which we call bone spurs or osteophytes. So if we could do something to stabilize the ligament, it's going to provide better stability to the knee and actually decrease the size of the bone spurs and improve the working capacity of this connective tissue. So we're going to show you what this looks like on ultrasound next. Hi everyone, my name is Dr. Greg Coppola, one of the integrative medicine doctors. And today we're going to talk to you about regenerative medicine. Regenerative medicine has caught a lot of attention recently because it's considered a viable non-surgical option to help people with connective tissue insufficiency. What do I mean by connective tissue insufficiency? That's a big term to describe ligaments, tendons, joints, cartilage that has begun to degenerate. We know that when we drive our cars, say 50, 60,000 miles, the struts, the rotors, and the brakes start to wear and degenerate. And sometimes they need replaced. Obviously, a knee can be replaced surgically. But a lot of patients come in and they want to know what their options may be that are not surgical. Certainly, steroid injections can quiet down some of the inflammation, but the wear and tear pattern that I just described with the ligaments, the tendons, the cartilage, and the joints can be treated in a different manner, either using your own blood, platelets, stem cells, or even a simple dextrose molecule. So today, we'd like to describe a specific circumstance with this particular patient, Dr. Karen. And Dr. Karen has a knee, and on the inside part of her knee, the medial aspect is degenerative. And so we're going to ask her to talk a little bit about her specific symptoms and what might regenerative medicine do for her.
So I've had knee pain for a good number of years. And I had an original injury on my right knee from a bicycling accident. And I thought that was my bad knee, but in actuality, as I was rehabbing that knee, my left knee started to become painful just with simple walking. I couldn't walk distances. Going up and down steps was very difficult. And so then I sought evaluation and care. And part of my history that caused some of my issues is as a young person, I was a soccer goalie for 9 years, and that caused a lot of trauma over time to my knees. And so I've actually had some of the regenerative medicine therapies done for my knees, and particularly my left knee, and I found it very beneficial.
So we have done a combination of platelet-rich plasma injections for this knee, along with prolotherapy with 15% dextrose, and also the 5% D5W called perineural for the nerves, the cutaneous nerves that influence knee pain. And so next what we're going to do is just sort of sequence how we would go about looking at the knee and some of the critical areas that are often painful for patients that have this connective tissue insufficiency. And we'll show you how we use our ultrasound to do that. So the ultrasound is a valuable tool that we use within musculoskeletal medicine every day to help assess what is going on with the patient's anatomy. And as I referred to the tendons, ligaments, joint, cartilage being degenerative, we can see how degenerative the tissue is. And so when we put the ultrasound on Dr. Karen here today, we're looking at what we call the suprapatellar space. And I'm looking at sort of that black region where the fluid is above her knee. And this specific area is a common area that we see fill with fluid because of the arthritic changes and some of the degeneration of the cartilage, ligament, and tendons that Dr. Karen has. So I would call this a mild to moderate effusion. An effusion is the collection of fluid in the knee. Dr. Karen, can you give a squeeze here? When she squeezes, you see a little more fluid come down from her quadricep muscle. So you can relax now. And there's even, almost looks like some white clouds in there. The white clouds are suggestive of some of her synovium that is thickening. Synovium is the inner lining of the knee that can become somewhat thickened with some osteoarthritic changes. Sometimes when we see that, it makes getting the fluid out a little more challenging, but this is one area that we look at specifically. And if we were to take fluid out of the knee, we turn the ultrasound like this. Let's give another squeeze. And you can see that black pocket, and we use the port right above her knee on the outside to go in and take some of that fluid out. You can relax now. The other area we want to check out here is the inside part of the knee called the medial joint space. And by looking at her medial joint space here now, we can see that she has some bony projections that are pushing up into the ligament called the medial collateral ligament. The reason those bony projections are there is because her knee is somewhat unstable. And when the body perceives that it's unstable, it will lay down new bone growth, and it's literally trying to fasten itself to the connective tissue. Unfortunately, these bone spurs, or what we call these, or osteophytes, can grow quite large, and they are pushing into the medial collateral ligament, which for Dr. Karen is quite tender in that region. The good news is the tissue around the bone spurs can still be strengthened, and certainly, as you will see a picture of Dr. Karen's x-ray with this case report, when there's not much space between the femur and the tibia, patients become candidates for at least a partial knee replacement or a full knee replacement. Dr. Karen is trying to avoid that at her young age of 53. So again, regenerative medicine is one way to try to stabilize a joint complex and working with the tissue that she has. So again, looking at down below here, we're looking at what we call the Hoffa's pad, which is the shock absorber in front of her knee between her patella, the kneecap, and the tibia. We've done multiple injections on this knee, and actually this area has actually filled in quite nicely. Her shock absorber looks much improved from what it did before. Usually it looks like Swiss cheese. There's dark holes in this particular region that are suggestive of degenerative changes. Actually, the body's own stem cell reservoir for the knee are located in this region, and again, hers looks improved from the original treatment. And then if I look at her outside part of her joint space, or what we call the lateral joint line, again, we see some small projections, but most of her bone spurs are on the inside. And we can also see her lateral collateral ligament, which is sort of the strut that holds the outside part of her knee. So by using the ultrasound, we can begin to assess the connective tissue of the knee. And by doing this, we can get a good sense of who might be good candidates for this type of regenerative medicine, either using your own platelets, stem cells, whole blood, or a simple dextrose molecule to induce change and stabilization in a joint structure such as Dr. Karen's.